Welcome back. This video is about hemophilia A and B. I will discuss the causes, signs, symptoms, complications and diagnosis. Now, hemophilia is a group of inherited blood disorder due to lifelong defect in the clotting mechanism. And this is the deficiency of coagulation factor 8 and factor 9. Now, hemophilia A, which is also known as classic hemophilia, is due to deficiency of factor 8, and hemophilia B, also known as Christmas disease, is due to deficiency of factor 9. Now, estimated frequency of hemophilia is 1 in 10,000 births, and hemophilia A account for 85% cases, while hemophilia B account for 10 to 15% cases of hemophilia. Now, the genetics. Hemophilia is an X-linked recessive disorder, and the genes of factor 8 and 9 are located on the X chromosome. So, males are affected and females are the carriers. Females can be symptomatic in rare cases when there is lionization of the X chromosomes. Now, in the picture you can see that if a father is hemophilic and mother is normal, non-hemophilic, then all the sons will be normal and all the daughters will be carrier. While on the other hand, if father is normal, non-hemophilic, while mother is a carrier, then there is 50% chance that sons will be affected, that is, they have hemophilia, and there is 50% chance that the daughters are carrier. Now, in 1/3 cases of hemophilia, there is no family history. In these cases, there is spontaneous new mutation. Hemophilia are found in all races and socioeconomic groups. Now, a few words about the pathophysiology. Coagulation consists of two processes, primary and secondary hemostasis. Primary hemostasis involves aggregation of platelets at an injured site, and an initial platelet plug is established. This is subsequently replaced by more stable, highly cross-linked clot through the secondary hemostasis, which involve the coagulation cascade. Now, factor 8 and factor 9 are both part of the intrinsic pathway of this coagulation cascade, and they are necessary for the activation of factor 10, which is the first step of the common pathway. So, a deficiency or defect in either factor 8 or 9 decreases the activation of factor 10, thus impairing the subsequent reactions which are necessary to create a more stable fibrin clot. Therefore, in hemophilia, clot formation is delayed and it is not robust. Patient with hemophilia slowly forms a soft, friable clot. Next, I will discuss the clinical presentation and complications of hemophilia. Now, factor 8 or 9 do not cross the placenta, so bleeding symptoms mostly present from birth or even in the fetus. Severe disease mostly present in the early life. Intracranial hemorrhage occur in 2% of the neonates and 50% of the preterms. 50% cases of this intracranial hemorrhage is spontaneous, and this has 50% mortality rate. It is the leading cause of death in hemophilic patient. Now, in 30% patient of hemophilia, there is prolonged bleeding after circumcision. There is also history of easy bruising and hematoma formation following immunization. There may be oral bleeding with minor trauma such as torn frenulum, eruption of the teeth, any dental procedure or tooth loss. There may be frequent episodes of prolonged epistaxis. Now, there may be retropharyngeal bleed, and it is a surgical emergency because it can cause airway obstruction. Another serious complication of hemophilia is intramuscular or muscle bleed. It is an episode of bleeding into a muscle determined clinically and or imaging studies associated with pain and or swelling and functional impairment. For example, a limp with calf muscle bleed. Now, iliopsoas bleed can cause hypovolemic shock and it can present as acute abdomen. There is vague rapid pain in the groin, and hip is held in flexion and internal rotation with inability to extend. Now, muscle bleed can present as neuropathy or compartment syndrome. Next important complication is hemarthrosis, that is bleeding into the joints. It is the hallmark of hemophilia. Earliest joint hemorrhage occur in ankles, but knees or elbows can be affected. Now, hemorrhage into the joint is usually spontaneous, but it can result from trauma. Joint bleed is defined as rapid loss of range of motion plus pain or unusual sensation in the joint, or palpable swelling or warmth of the skin over the joint. Now, in hemophilic patient, target joint can develop. It is a joint in which 3 or more spontaneous bleed have occurred within a consecutive 6 months period. Now, here are some other complications. There may be hematemesis, hematochezia or melena because of acute gastrointestinal bleeding. There may be acute retroperitoneal bleeding which present as abdominal pain, abdominal distension or paralytic ileus. Now, there may be renal hemorrhage which present as painless hematuria. However, ophthalmic hemorrhage is rare. Next is clinical classification of hemophilia A and B. First is severe hemophilia. In this factor 8 or factor 9, clotting activity is less than 1%. 70% cases of type A and 50% cases of type B have severe hemophilia. In this, spontaneous bleeding occur in the joints, muscle, CNS or deeper organs. It is diagnosed in the first year of life. Next is moderate hemophilia. In this, the factor 8 or factor 9 activity is 1 to 5%. Now, bleeding results from minor trauma and rarely it may be spontaneous. It is usually diagnosed before 5 years of age. And third is mild hemophilia. In this, the factor 8 or factor 9 activity is more than 5% and significant trauma or surgery is required for bleeding. Now, here it is important to mention that patient with 30% factor activity may not need any supplemental clotting factors in minor surgeries. Now, life-threatening hemorrhage in hemophilia occur at 3 sites: intracranial, retropharyngeal and retroperitoneal. Now, the diagnosis of hemophilia. In the laboratory studies, there is prolonged APTT, normal PT, normal bleeding time, CBC is normal or hemoglobin is decreased, and ESR is normal or raised. Now, correction or mixing studies are also done in hemophilic patient. In this, mixing of the patient plasma with pooled normal plasma result in the correction of APTT in hemophilia. However, diagnosis of hemophilia is confirmed by specific factor assay or DNA mutational analysis. Now, von Willebrand assay should also be done to rule out von Willebrand disease. Factor 8 to von Willebrand ratio less than 0.07 indicate carrier state. Now, Nijmegen-Bethesda assay is used to assess inhibitors titers. Inhibitors are suspected when prolonged APTT is not fully corrected by mixing studies. Now, these inhibitors are factor 8 or factor 9 specific antibodies, and these may develop in 25 to 35% of the patients who received infusion of factor 8 or factor 9. Now, X-ray, ultrasound or MRI of the target joint shows thickening of the synovium, increased echogenicity, hemosiderin deposition and destruction of the cartilage. Okay friends, thanks for watching. Please like, share, comment and subscribe to my YouTube channel for more informative videos.